Let's continue the discussion of cardiac physiology. In here, we will talk about the mechanical events that occur in the heart, followed by the electrical events, which we worked on in the previous lecture. The action potential is generated and it is spread throughout the heart, and soon after action potential, as you already know, the muscle begins to contract. So the mechanical events involve the contraction of the chamber, pushing blood from one compartment to the other via the valves that are open or through the blood vessels that the blood has to move. And then the relaxation phase is where the chambers begin to fill with blood. So these mechanical events are summarized as heartbeat or a cardiac cycle. So cardiac cycle deals with one heartbeat, and the details of this one heartbeat is what we talk about in the first part. The second part is looking at how much blood is ejected by the heart, that is cardiac output. In 1 minute, how many heartbeats are there, how much blood is pumped out, and the mathematical calculation that we need to understand the cardiac output, and the factors that affect the heart rate or the stroke volume. So let's begin. Cardiac cycle is organized into two parts, systole and diastole. Systole is the contraction of the muscle that makes the blood move to appropriate chambers or blood vessels. Diastole is the opposite, that is the relaxation of the muscle. You could organize systole into atrial systole and ventricular systole. Similarly, atrial diastole and ventricular diastole. Atrial systole and atrial diastole are of less significance compared to the ventricular systole and ventricular diastole. So if you come across the terms systole and diastole, it often refers to ventricular systole, ventricular diastole, because unless we have that atrial before systole, we typically refer to these big terms as ventricular events. There are a number of different steps to talk about in here. So first of all, where do we begin the discussion of cardiac cycle? This is an ongoing process. The chambers contract, relax, contract, relax. This cycle goes on. So we have to pick a place so that we can go through the steps in a detailed manner. So let's assume that we are looking at the end of one cycle so that we can look at the events in the end of the previous cycle and then how it leads to the beginning of the new cycle. If that's the case, in the previous cycle, the blood has already been pumped and the ventricles are in diastole, and that is where you can organize this into two parts, early diastole and late diastole. Diastole is a long event. About 2/3 of the time in a cardiac cycle is spent in diastole. So in early diastole, that is soon after the blood is pumped, when the ventricles are going through the relaxation phase of contraction of the cycle, the atria are beginning to fill with blood, and AV valves at this point would be closed. It is the filling of blood in the atria for some time. The volume in the atria builds up, and the pressure in the ventricles is zero because of the diastole and also the blood having left. There is still some blood left in the ventricles at this point, however. This is what you call as end systolic volume. At the end of systole, there is about 1/3 of the blood left, end systolic volume. It's about 50 to 60 milliliters. However, the pressure is zero. So as the atrial filling with blood, the pressure in here increases, which passively makes the AV valves open, and also passive filling of the ventricles occurs. Passive filling, gravity pulls blood down, pressure difference fills blood down. So about 70% of the filling from the atria to the ventricles is all passive. However, at some point, atrial systole pushes any remaining blood from the atria into the ventricles, that is, during late diastole. So when all of the blood from the atria is pushed into the ventricles, the pressure in the ventricle obviously raises, and AV valves, because of the pressure difference, close and prevent backward flow of blood back into the atria. So it's an interesting situation in the heart. All of the blood would be in these two ventricles. AV valves are closed, semilunar valves are closed. And this is what you call as end diastolic volume, EDV. End diastolic volume is the maximum amount of blood that you can expect in the ventricles. And when the blood is all in the ventricles, that would make the muscle wall expand, and that would be, some stretching that's going on in the wall. And of course, there is contraction that is occurring in the ventricle. Initially, it's isovolumetric contraction. Isometric contraction, we already know, that is when the muscle fibers are contracting, but there is no actual movement. That's because the resistance of blood sitting in the chamber is greater than the pressure that is generated by the muscle fibers at this point. Isovolumetric refers to the volume being the same. The volume of blood will not change anymore because the AV valves are closed. So this is contraction that is occurring. Volume is constant, and this is isometric contraction. So this goes on for a while, and eventually the pressure would exceed the pressure in the appropriate blood vessels, aorta for the left ventricle and pulmonary artery for the right ventricle. When the pressure exceeds the pressure in these arteries, the semilunar valves open and blood is actually ejected. That is ventricular ejection, and the amount of blood that escapes the heart is what you call as stroke volume. This is about 2/3 of the blood that was in the ventricles during end diastolic situation. So about 130 milliliters of blood was there. About 2/3 of the blood is ejected, and that's what we call as stroke volume. ESV, end systolic volume, is the blood that's remaining in the ventricles at the end of systole, at the end of the ventricular contraction, at the end of the closing of the semilunar valves. So when the blood is ejected into the aorta, for example, from the left ventricle, the pressure difference is in such a way that there is increasing pressure in the aorta compared to the decreasing pressure in the left ventricle. This difference makes the semilunar valve close suddenly to prevent backward flow of blood. And that is what is causing the valves to close, and ESV is the remaining amount of blood in the ventricles. At this time, maybe we should talk about two heart sounds. One of them is lub, the other one is dub. When AV valves close at the end of atrial systole, that's the cause for first heart sound. When the semilunar valves close at the end of ventricular systole, that's the cause for the second sound. So closing of AV valves, first heart sound. Closing of semilunar valves, second heart sound. So we have another interesting situation at the end of systole. Semilunar valves are closed, AV valves are closed, least amount of blood that can be expected within the ventricles, that is ESV. That's approximately 50 milliliters, about 40% of EDV. EDV is end diastolic volume. Ejection fraction is the ratio of the stroke volume and the end diastolic volume. This is shown in this equation. Here EF equals SV over EDV. So then we start the cycle all over again. Early ventricular diastole, which we started off here. Look at the time it takes, 0.4 seconds. Then the isovolumetric relaxation, that is the volume of the ventricles, volume within the ventricles has not changed. It is still ESV, and the muscle is going through the relaxation phase. So the volume is the same and relaxation occurs. This goes on until the AV valves open and the ventricular filling occurs again, and that would be this phase. So these are the steps we need to understand. They happen one after another in a systematic way, and the best thing is to visualize this. No illustration, no writing can basically explain and do the justification of what exactly happens within the heart. In this illustration, the dark green here is showing the ventricular contraction ejection phase. So that is shorter, about 1/3 of the cycle. And relaxation takes up about 2/3 of the cardiac cycle. So as I mentioned, relaxation part is much longer. In any case, let's talk about this in a step-by-step manner. So we will start with isovolumetric relaxation. That is when the semilunar valves are closed, AV valves have been closed for a while, and there is muscle relaxation. Atria that are filling with blood open the AV valves, and there is that passive filling of blood into the ventricle. So this is late diastole. When there is filling of blood, it's no more isovolumetric relaxation because the volume is changing. And now the atrial contraction. Atrial contraction, atrial systole pushes any remaining blood. This is where we can talk about how insignificant atrial event is. 70% of the filling has occurred even before atrial systole. If atrial systole did not occur, the blood that has filled the ventricles will still be pushed out. That means atrial systole is not as critical. So atrial systole, all of the blood is in the ventricles, AV valves close, first heart sound, and then the isovolumetric contraction is what you see in the ventricles first. So the dark color meaning the blood is all in the ventricles. AV valves are closed, semilunar valves are closed, and isovolumetric contraction. This goes on for a while, and then when the pressure is sufficient to overcome the pressure in these two vessels, the semilunar valves open, blood gets ejected into these vessels, ventricular ejection, and then that's what is shown in these arrows and these arrows. At some point, the pressure difference between the two blood vessels in the chambers makes the semilunar valves close, and that's when you start isovolumic or isovolumetric relaxation. Now connecting the electrical events to the events in the chambers and the blood vessels. So here is a P wave, that is atrial depolarization. That's followed by atrial systole. So action potential first, contraction next. So it happens during PQ interval. Atrial systole is during PQ interval, or PR interval for that matter. Then you have the QRS complex, that is ventricular depolarization. Note that it has to occur first and then the ventricular systole. Ventricular systole happens between the QT interval. So this takes up whole of this time, and then the ventricular diastole follows ventricular repolarization. So that is how one cardiac cycle is connected to the electrical events. It's extremely important for us to make this connection. Electrical events first, mechanical events next. Here are some details to understand cardiac cycle even better. Let's talk about aortic pressure. Aortic pressure varies from approximately 80 to about 120 millimeter mercury. When it is diastole, you notice the pressure is about 80, and right when the blood is pushed into the aorta, that's when the pressure suddenly goes up to 120. semilunar valves are open, blood is pushed into the aorta, and that is when the pressure jumps to 120. And then as the blood moves away from the heart, the pressure drops. Semilunar valves are closed, blood is moving further away from the heart, and as the ventricles are in diastole, there is no filling, the pressure gradually drops and reaches about 80 millimeter mercury. So that is the change in the aortic pressure within one cardiac cycle. Let's talk about ventricular pressure. The green line here varies from 0 to about 120. During diastole, ventricular pressure is 0. When AV valves are open, there is some filling of blood that is in the late diastole. The pressure picks up a little bit. When AV valves close, the pressure is not 0, but not too great either. Isovolumetric contraction makes the pressure build up, and it has to generate this high pressure and exceed the pressure within the aorta. The pressure in the aorta would be about 80, 90. So it has to exceed that pressure to open the semilunar valves. And then as it pushes blood into the aorta, the pressure drops suddenly to 0. So here you're looking at semilunar valves closed. That is when the blood is ejected and the pressure suddenly drops. So it's back to 0. This is talking about just the left ventricular pressure. Please note that the right ventricular pressure is much smaller than the left ventricular pressure. The reason being, a right ventricle has to pump blood to the lungs, which are pretty close to the heart, whereas the left ventricle has to pump blood to the entire body. So that's one key difference between the right and the left ventricle. Other than that, the timing of the pumping, the volume of blood they handle is all exactly the same. Atrial pressure is the other one that is shown here. Atrial pressure is changing just a little bit. When it fills with blood is when the pressure goes up to about 10, and then when it goes through atrial systole, it drops back to 0. And atrial pressure filling and AV valves close, that is when the atria have released the blood from there to the ventricles. All right, so that is connected with the heart sounds. First heart sound is when the AV valves close. Second heart sound is when the semilunar valves close. Here is some detail. Aortic pressure starts increasing during systole. After the aortic valve opens, aortic pressure decreases toward the end of the ejection phase. Aortic pressure decreases slowly during diastole because of the elasticity of the aorta plus blood flow to the periphery. Now let's get to some math where we talk about heart rate. How many times does the heart beat in 1 minute? So the duration is what you can calculate from the EKG. Our interval is approximately 0.83 second. Heart rate, therefore, is the time per minute. So many seconds, 60 seconds per minute, and this is how much time it takes for one beat, 0.83 seconds per beat. And so this gives us a mathematical assumption of 72 beats per minute. Ejection fraction, that is the fraction of blood that's ejected. We are looking at end diastolic volume of 130, end systolic volume of 60. So ejection volume, stroke volume is 70. So ejection fraction is, as you learned, this would be stroke volume over the end diastolic volume. So this is the ratio between stroke volume and end diastolic volume. That is approximately 55 to 60%. So if heart rate is 72 beats per minute, what's cardiac output? Cardiac output is heart rate times stroke volume, 72 per minute. We calculated that here. And then 70 milliliters using this volume here you have approximately 5 liters per minute ejected in a normal situation. Same thing is shown in an animated fashion here. Cardiac output equals stroke volume times heart rate. So to increase cardiac output, you can either increase stroke volume or heart rate, or both. So this is stroke volume, the blood coming out of the heart. So here is a summary slide of factors affecting heart rate or factors affecting stroke volume. There are a number of factors that are involved. We will look at some in detail as we go along. Autonomic innervation can affect the heart rate to be higher or lower, certain hormones, and exercise, age is another factor. Factors affecting stroke volume, some of them are the same factors: size of the heart, gain, exercise, gender, contractility, that is the force with which the heart contracts, duration of contraction, preload, we will look at this, afterload, these will be understood. So heart rate can be affected by various factors. Stroke volume could be affected by so many factors. Stroke volume, as we know, is end diastolic volume minus end systolic volume, EDV minus ESV. So cardiac output is HR times SV. What is cardiac reserve? This is the hidden capacity of the heart to do much more work. When you're exercising, for example, your heart rate would go to about 180 or 200 beats per minute. What would that do to the cardiac output? Well, look at this. Your output is 15 to 20 liters per minute. In other words, you have increased the output fourfold. That is the hidden capacity of the heart. So it can do this at least 300% more than the normal level. And that is what you call as cardiac reserve. It doesn't happen all the time, but only when situation is such that the heart would work more and cardiac output increase. So now let's talk about the factors that affect heart rate. So we're taking one thing at a time. Heart rate first, stroke volume next. Heart rate is what we're working on. Neural influence is what we want to talk about. That is strictly autonomic. Parasympathetic decreases heart rate and sympathetic stimulation increases heart rate. So how does parasympathetic system decrease heart rate is explained here. It increases potassium ion permeability. So more permeable the membrane is for potassium ion, more potassium ion would leave, and that means the membrane would remain in a hyperpolarized state longer. So the duration would be longer. The slow opening of the funny channels and those transient type of calcium channels. That is another way it would slow the action potential in the nodal fibers. Sympathetic regulation is exactly the opposite, fast opening of the funny channels, and it also has another effect, that is force of contraction. This is at the ventricular muscle fibers. The force of contraction and the opening of funny channels is how you can increase the heart rate. So in order to regulate stroke volume, you have to consider three things: preload, afterload, and contractility. We will look at each one next. What is preload? Preload is the amount of blood that's in the ventricles. At the end of diastole, when the atria have completed their contraction, all of the blood is in the ventricles. That's what you call as EDV, or end diastolic volume. The amount of blood that is in the ventricle is preload. So greater the EDV, greater the preload. What could cause EDV to be greater? Is it even possible? Yes. Duration of diastole. Longer the time period the heart spends in diastole, more blood would be collected. Increased heart rate decreases EDV. So there is an inverse relationship. If the heart is beating faster, obviously there is less time for it to fill with blood. So that is the duration of diastole. Longer means lesser the heart rate, greater the EDV. Faster the heart rate, lesser the EDV. That's the kind of relationship. Venous pressure. So this is a totally different topic that we will understand better when we talk about the blood vessels more. But for now, let's think about the pressure within the vein for a minute. The veins have the least blood pressure among all the blood vessels. Anytime there is any mechanism that increases the pressure within the veins, that would increase EDV because there is more blood being returned to the heart in that situation. What could increase venous pressure? Exercise, meaning muscle contraction, that would squeeze the veins more because veins are located between the muscles, especially in the lower limbs. So there is more blood that is being returned to the heart. That's one example we can think.